anthropologist and author Anita Hannig is with us today to talk about medical aid in dying, a subject that can be controversial and confusing. You're connected with the Heart of Hospice. I'm Helen Bauer, here with Jerry Fenter.
Whether you're a family caregiver or an end-of-life professional, we're here to enhance your hospice experience by connecting you with information you can use about end-of-life care.
Today's episode is sponsored by the Love Always Project. The team at Love Always understands that while loss is a natural part of life, it's a topic that a lot of people would rather just not think about. On the Love Always Project website, you'll find support related to grief, loss, and bereavement, as well as funeral pre-planning. With all the overwhelm that comes with the loss of someone you love, it's great to have the resources the Love Always Project provides. Check out their website at lovealwaysproject.org.
Everyone working in end-of-life care should be knowledgeable about medical aid in dying. We would recommend cultural anthropologist Anita Hannig's book, The Day I Die, The Untold Story of Assisted Dying in America. The book is unbiased, based on 5 years of immersive research. In telling the stories of ordinary Americans who decide to seek medical assistance in dying, Ms. Hannig uncovers the stigma against assisted dying and why someone might choose an assisted death. You can find The Day I Die, The Untold Story of Assisted Dying in America at anitahannig.com.
Okay, so what we want to say up front before you listen to this episode, this is a great episode. There's a lot of good information. However, we are talking about a very controversial subject that can be upsetting. It can, I think, inspire a lot of strong emotions and strong opinions. So we are going to let you know in advance that we are talking about medical aid in dying. It's not legal everywhere in the United States. It's considered unethical, immoral by some people. And we'll say up front, we are also not endorsing or condemning the practice. This episode is all about giving you education and information.
Which is really what we're all about anyway.
Yes.
So we feel like that having this information, especially if you're an end-of-life professional, is important information to have, especially if you are in a state that has a medical aid in dying law. There may be some of your patients who choose to use this legal way to die and to choose when they die. So this is going to be very important for you to hear this message.
So our guest today is Anita Hannig. She's an associate professor of anthropology at Brandeis University, where she teaches classes on medicine, religion, and death and dying. Her work explores the cultural dimensions of medicine with a particular focus on life's bookends, birth and death. She's emerged as a leading voice on death literacy, and over the last 5 years, she spent hundreds of hours talking with patients, families, physicians, lawmakers, and activists all across the United States.
And all that research has now been put into a book that she has written called The Day I Die, The Untold Story of Assisted Dying in America. So this is what we're going to be talking with her about today. And she describes in this book what she learned about how assisted dying is transforming the way that Americans die.
So I would also say that if you know of someone who is seriously ill, or a caregiver for someone with serious illness, please share this episode with them. As end-of-life professionals, we get asked about these laws, death with dignity laws, and I think it's important that we're educated, we're aware. It doesn't matter whether we endorse it, because the fact of the matter is we don't endorse a lot of the things our patients and their families do. But that's not the point. The point is, are you educated so that when you get asked, can you provide the education that your patients and families need?
Yes, and Anita Hannig and her book will help you to understand the complete story. And she talks about not only the legal aspects of it, but the emotional aspects of it.
The personal aspects of it.
From the patient side as well as from the family side.
Mm-hmm. She talked about the legalities, the science behind the drugs themselves, the laws, and how people can take advantage of death with dignity laws. She also talks about the burdens of medical aid in dying. I could not put the book down. It was very interesting. So without telling her full story, here's our conversation with anthropologist and author Anita Hannig.
Anita, we are so happy to have you on the Heart of Hospice podcast. Welcome to the podcast.
Thanks so much for having me. I'm so excited.
We're excited too. And we are going to talk about your book, but we're going to talk about other books for just a minute. So we want to ask you, if you were going to give a book as a gift, tell us what is your favorite book to give as a gift?
Oh my God, what a difficult question. I would say I've been really taken by Michael Pollan's work around psychedelics and how they can open and change your mind. I haven't read his most recent one, but the one before that, How to Change Your Mind, it's called, is kind of one of those books that changes your entire paradigm around reality. And that's probably one I would give to people as a read. And I have actually given that to some friends, loaned it out. And it actually has something to do with my topic as well, because he talks about the promise of psychedelics for terminally ill patients who are afraid of death. So that's where the parallels are. But in general, I would say his book is really daring, very immersive, and fundamentally life-changing, I would say.
Interesting. So tell us the name of the author again.
Michael Pollan.
Michael Pollan. Okay.
Mm-hmm.
Very good. Well, that may be one we have to
Look at that one.
He's very famous.
Wonderful. Wonderful. Well, we want to talk about your book today. So you have a book. The title is The Day I Die, The Untold Story of Assisted Dying in America. So this is very interesting as well. And Helen has had the opportunity to read your book and has some wonderful things to say about the information that you share. So we want to start off by doing this. Tell us more about how you came to write this book. What was your goal in doing this? And what was your approach to the research about medical aid in dying?
Yeah, so I'm afraid there isn't really a juicy origin story here. I got into this topic kind of by accident because I was showing a movie called How to Die in Oregon in one of my classes. And I think it was my medicine and religion class at Brandeis University, where I'm an associate professor of anthropology. And I showed the movie in class, and while watching it, already thought, oh my gosh, this is so interesting. What a fascinating topic. I should potentially consider doing this for my next research project. And up until then, all my research had been on birthing in East Africa and Ethiopia and birthing complications. And so this really felt like, okay, we're going over to the other side. We're looking at life's bookends. So I wanted to kind of dive into how people's options and ways of dying have shifted in the wake of having access to assisted dying in the United States. And at the time, there were only a handful of states that allowed assisted dying. And now we're up to 10 states plus Washington, D.C. So ever since I started this research, more states have come on board. But the approach, you're asking about the approach, Jerry, and maybe I'll explain this a little bit to listeners. So because I'm an anthropologist, I took an anthropological approach. So what does that mean? So anthropologists study the diversity of human experiences all over the world. Some people tend to think, oh, anthropologists, dig up old graveyards or grave sites or what have you, bones,
right.
pottery shards. That's archaeology. So I'm a cultural anthropologist or medical anthropologist specifically. And so I take a look at the culture of medicine and how we practice medicine and all of our conceptions of the body, of the self, of medicine as a tool, and how we can kind of think about that in our country, in other countries. And anthropologists study human experiences from a relativistic point of view. So we don't assume and we don't impose our own rationality or one ethical point of view on someone, and we don't judge. We're trying to enter these different contexts by being completely curious about other life worlds and and taking this hands-on, very immersive approach. So that means we don't just go in and do these interviews and then we leave. We kind of embed ourselves and immerse ourselves in the communities that we study. And that's the whole point of anthropology, that you're not standing by the sidelines, but you actually become part of what's happening. And we have this saying, you do as they do. So we have this tool in our toolkit called participant observation. That means you observe, but you also come to participate in what's happening. And only through that are you able to think yourself into other people's shoes, into their minds. And that kind of gives you a privileged vantage point when you're reporting on what these people experience and what some of their struggles and are, and some of the things that are meaningful to them and things like that.
So that was one of the things that struck me about the book, is this immersive experience that you had. You worked as a hospice volunteer. You worked alongside and observed a woman who was a guide for people who were pursuing medical aid in dying. And there were several cases that you followed through, people with different diagnoses, some with cancer, some with neurodegenerative disorders like ALS. Very observational and yet not distanced. And I think that made a lot of difference in how you were able to present the cases and present the information and what those scenarios actually look like. They were very tangible, for lack of a better word, even relatable, I guess. And maybe as an end-of-life professional myself, I've been in those situations with those patients, and I know what they look like and what their family dynamics have been. But that immersed, observant approach is very impactful in the book, in my view.
Yeah, it made sense to me, especially given this topic, because I really wanted to understand assisted dying from the inside out. I really wanted to uncover the lived experiences of people who availed themselves of the law. So there are a lot of theoretical debates, abstract, even theological debates about the pros and the cons about assisted dying. And a lot of them aren't really based in reality. But I wanted to understand what is it like for someone to take a drink to end their life, knowing that this is the last thing they will do. How do you find the courage to do that? How do you get your family on board? How do you make that decision? How are you so sure that this is what you want? And how do you say goodbye? And how do you let go? How does the family let go? And how do doctors find it in themselves to shepherd you through this when doctors are going against the grain of some of their own medical training, right? I mean, we can talk later about how some doctors think assisted dying is antithetical to the Hippocratic Oath, and how the doctors that I came to know really think that if medicine is there to alleviate suffering, and in their eyes, in the patient's eyes, these are patients that absolutely suffer at the end of life, then there's an obligation by medicine to end their suffering. And I was really struck by that. And so the immersive approach, going back to that, especially in the room, when you're in the room, and Helen and Jerry, you can relate to this, when you're in the room with a terminally ill patient and their family, you don't stand on the sidelines. You just become part of what's happening. You do whatever needs to be done. And you're not sitting there with a notebook taking notes. You are becoming part of the circle. It's a group effort, right? To carry somebody over the threshold together. And so you become part of that group to do that. And so it felt, I don't know, it was an expression, I guess, of my wholehearted involvement, that I became privy to that. And I became an active participant in these scenes of seeing somebody out, basically.
So how many experiences did you have like that during this time you were doing the research?
How many planned deaths?
Yes. Yeah.
So just a handful, because it's also an extreme privilege to be invited into that kind of space. Of course, I interviewed, so many patients who I didn't end up attending the death of, because that is also then a decision that's totally up to the family. And I would never push that on anybody, right? But the patients that did allow me to be there with them are the ones that felt very strongly that they wanted this death to mean more than it meant to their family. to resonate beyond themselves and their small circle, and to teach others that this is an option that should be available, that is available to them. And they just wanted this to be really meaningful. I mean, I described one scene of a woman, Jean, who actually used her last couple of minutes before she died to go on an advocacy pitch about assisted dying and how the name of the law needed to be changed and the taste of the medication needed to be changed. And, and I was, of course, mortified that she spent the last couple of minutes of her breathing, life talking to me and not to her family. But her family later told me that was just like Mom. She would stand up for something that she believed in. And this is how she conducted herself even on her deathbed.
Well, in Jean's case, I think was probably pretty characteristic of what a lot of these patients go through, because she had several kids. She also had, I believe, a twin sister. Her oldest child, who lived at a great distance, a son, was very adamantly opposed to Jean availing herself of the lethal medication, as was her sister. And so not all of her kids were present when she took the medication. And I was really struck by this because I think we see that in hospice a lot. You've got a family member that is distanced for whatever reason, whether it's disenfranchised from the family, they choose to be remote, or they just live remotely. And in fact, I marked it because I wanted to talk about that. You say the son had lived on the East Coast, so obviously all the way across the country, and hadn't visited his mother in years. He hadn't witnessed her decline the way her other children had. But the two daughters believed that he held an image of his mother from a long time ago, before the excruciating pain in her legs and her other health issues began. We see that a lot in end-of-life care, where you have a family member who really has had what I call the luxury of distance. You're not privy to what's happening, so you're not making those hard decisions. And so I think there's a luxury of distance for a lot of people who would look and say, medical aid in dying is this and this and this, and this is how I perceive it as suicide. It's a mistake. It's the wrong way to do it. It's unethical. But wouldn't you say that a lot of that comes because there's a lack of accurate perception, a lack of knowledge? I mean, as a healthcare practitioner, I was completely unaware of what the actual process was. It's fairly lengthy and fairly laborious just to be approved to do the process.
Oh, absolutely. And there's so many misconceptions about assisted dying, and that's why I wrote the book. Even in states where it's been legal, here in Oregon for 25 years, and everybody thinks they know how the law works, and they don't. And so many people think that there's one magic pill you swallow. And I have a whole chapter about why that's not the case and how difficult the pharmacology, just even the pharmacology of dying is.
Yeah, so there's a lot of people who are involved in this process. I mean, you have the doctor, you have the pharmacist, you have the patient themselves. And so there's a lot of people who are involved in this. Are there also mental health practitioners who are involved in it?
There can be. In most states, if there are any questions as to the soundness of your mind and whether or not you're suffering from a mental illness that could affect your decision-making ability, you have to be referred to a mental health consultant or a mental health practitioner, a psychologist, psychiatrist, and they basically have to do an evaluation and determine whether or not you are of sound mind.
Well, and isn't that conversation an ongoing, especially with patients that have underlying dementias, things like that? There is an ongoing evaluation all the way up until the moment that they take the medication. Do they understand the intent? Do they still have the same intent? Do they grasp the full concept and the consequences, obviously the lethal consequences of taking the medications? Isn't that an ongoing process during the whole inaction of the Death with Dignity law?
Yes, but if you're very technical about it, the law basically ends once you write the prescription. So you are able to carry out an assisted death without the presence of a doctor or a health professional. It's recommended, but and this is where I think the laws could be, I don't know how you would improve that, but could be potentially clarified a little bit. So right now you could take the medication without having somebody say at the very last moment, oh, do you still want to do this? But in reality, in Oregon, I think it's half of all assisted deaths that are attended by a healthcare professional, and volunteers up until a few years ago didn't even count as healthcare professionals. So their numbers were not reported in that statistic. Most of the deaths, actually all the deaths I attended, there was a physician there. And I would say that's more common than it isn't, but it doesn't have to be the case. And if there is a physician there, and even if there's a volunteer there, they will go through that protocol, right? They will ask, who's making this decision, or whose decision is this? Are you sure you still want to do this? And what does this medication do to you? So, and if the patient isn't able to satisfactorily answer those questions, then they won't proceed. And that has sometimes happened. Not a lot, but it has happened. And in the case of early dementia, you can still have an early dementia diagnosis and still be of sound mind. But it's really getting into that territory where people are afraid they might lose their capacity. And of course, that diagnosis by itself wouldn't qualify you for an assisted death anyway, because you have to have a 6 months prognosis.
Right. So a lot of the patients that are using the Medical Aid in Dying Act are, in fact, hospice patients. They've been given a 6-month terminal prognosis.
Yeah, I think it's over 90% in Oregon now, and everywhere else too. Close to 90% of assisted dying patients are hospice patients. And that's also something that I think a lot of people find really surprising, because there's this idea that hospice or palliative care and aid in dying are kind of mutually exclusive. And in my book, I go to great lengths to show that they're actually complementary. And assisted dying isn't a failure of palliative medicine. And it's a tool, right? It's one tool in the toolkit. And I've talked to many patients. I'm thinking of, I think it was in chapter 8, where I talk about this pair of sisters, where one sister had a really aggressive brain tumor, and they had submitted her assisted dying application, but they really said, hopefully we won't have to use it, because hopefully hospice will take us all the way and we will never have to use it. And I'm not going to give away what happened, but hospice can be actually a great partner in an assisted death. And there are many hospices that are very supportive of assisted dying and plenty who are not, because there's still this fear that a lot of people already hesitate to be on hospice because they're afraid of embracing death in this really direct way, or because it feels like if you are on hospice, then you have accepted. There's a certain piece of acceptance there that death is coming. And a lot of people are not willing to go there. And so hospice practitioners felt that if they were actively involved in assisted deaths, then people would be even less likely to choose hospice. Because they didn't want to have this impression that then death is sped along in any way. But that's, of course, not what happens with assisted dying. But I would say overall, the misconceptions of healthcare workers really have contributed to some of the hesitancy of physicians to become a prescriber. I mean, you need a prescriber and then you need a consulting. So you need actually 2 physicians in most states, except in New Mexico, which has a slightly different law. And you have policies by hospice organizations that are against assisted dying, and this idea that, well, if medicine can prolong somebody's life, then there's no room for medicine at the end of life. But there definitely is.
I think there was one physician that you talked with that felt like it was a physician's job to stay with their patients all the way up to their death, that the role of the physician shouldn't end the minute the patient said, I'm ready to die. It was an abandonment, a professional lapse. And you talk a lot about that, about how medical practitioners, physicians, view their role in medical aid in dying. Some to the point where their religious or their ethical, moral beliefs prevent them from even having those conversations with their patients, to the point where they would not record if the patient made the utterance, which sets the process in motion in a lot of states, where the patient said, I want to receive a lethal dose of medication so that I can die. That has to be on the record. Well, there are physicians that won't even document that because they don't want to be any part of any of the steps where that process would be set in motion. So there's a lot of resistance in the medical community, and I would say there's a lot of ignorance, and I offer that respectfully. It's just a lack of education among the healthcare community, because this is not the culture that we have had when you medicalize death. And in my career, that's all I've known, because I've been a nurse 32 years. That's what I was trained, and that was what I was taught. When you medicalize such a natural event, then it sort of goes against our grain, goes against our training, what we've learned as a professional culture, what we should be doing. So I understand the resistance that's there. And then, of course, any hospice agency can choose, if they're a faith-based agency, they might choose not to participate. And then on an individual level, if you are a hospice nurse or social worker or chaplain at an agency, you can also choose not to participate with those patients, even though your agency may assist those patients. So there are a lot of different levels where healthcare practitioners can pull away from that.
And I think it's important to have those in place. I think it's really important that physicians or healthcare workers aren't coerced into participating in assisted dying. I think
Right.
that's an important part of the law, but California recently amended its law to then still require, even if a physician is unable to assist, to be upfront with patients about that. And that's all they're asking, to say, well, if you have a policy against assisted dying, let your patients know so that they don't waste precious time at the end of life. And even if you don't want to pursue an assisted death with your patient, record it in their medical chart, and submit the medical chart or transfer the medical chart when that's requested. Because you see in Oregon, so many cases I describe in the book where, as you mentioned, a patient's physician wouldn't even record this first oral statement, I want to pursue assisted dying, in their medical chart. And that statement starts the 15-day waiting period in Oregon and in many states, or actually all states. But if nobody records that in your medical chart, then the 15-day waiting period cannot start. And I cannot emphasize enough how many patients actually never make it through the 15-day waiting period. I mean, there aren't hard and fast statistics about that, but the physicians I've talked to who have, collected their own numbers on this, they say it's about a third of all patients who are so sick, they don't live past those 15 days.
Yeah, it's a very narrow window of time. And for a lot of them, their clinical status deteriorates such that they no longer qualify under the requirements of the law. They're not able to self-ingest. So there's a fine window, very small window there of time, especially for, I think, the neurodegenerative cases, things like ALS. Those were some of the cases that you described that were the most time sensitive, because the patients lose that function to self-administer.
Mm-hmm. Yeah, and self-administer, that can take the shape of drinking, but if you can't swallow, then there are some other ways that if you still have use of your hands, you can push the plunger on your feeding tube or on your rectal catheter. But that's the conundrum with ALS, right? A lot of ALS patients, if their deterioration is very fast, they have lost the ability to use their hands. In some cases, they are losing their ability to swallow. So that window that you're talking about is very, very serious, and it threatens to shut very quickly. And so this is one of the paradoxes of these laws as well. I mean, they benefit a lot of people, but some people are too sick to use them. If you can no longer self-administer, if you can't be that agent of your own death, you can't use the laws.
The Love Always Project is a grassroots movement created to encourage people to pre-plan and pay for their funeral as the ultimate act of love for those they will leave behind. Many people don't know they can plan their funeral in advance, but most people who do know they can pre-plan simply choose not to act on the opportunity. The Love Always Project knows there are benefits to completing funeral pre-planning. such as minimizing pain for your loved ones during what can be a difficult time of grief and mourning, and leaving a final connection with those you love that can mean so much. By promoting discussion about end-of-life issues and providing expert information, Love Always helps people design a better farewell. Funeral pre-planning and funding can reduce financial and emotional stress on your loved ones, giving them time to grieve, and giving you peace of mind knowing your wishes will be carried out. Follow the Love Always Project on Facebook and Instagram, and check out the Love Always Project forum page to find a space to share and learn about the many aspects of end-of-life issues. Visit lovealwaysproject.org to find the support and resources for funeral pre-planning that you need.
So let's talk about some of the psychosocial and spiritual considerations for this. Family dynamics. I worked with a social worker who used to call them the dreaded FDs, right? The family dynamics. And we talked about this a little bit earlier, where you have family members that disagree and they won't assist with it or even mix the medications up, even families that are supportive of the patient. So there's a lot of psychosocial, spiritual considerations to take. Is there anything in the laws or in how these cases are handled where there's an inclusion of psychosocial professionals, spiritual care professionals? Because in hospice, obviously, we have an interdisciplinary team that cares for the patient holistically. How is that addressed in medical aid in dying cases?
This isn't addressed. And that partially has to do with the fact that the laws can't legislate everything. The laws can basically give you a blueprint of requirements to follow, but then there's a lot of social psychological support that basically patients often get through hospice. And all the law says is that the law recommends that the patient tell their family. They don't require that the family is informed, but it's recommended. And I think most patients do tell their family. But I think this is where hospice really plays such an important role for most patients because of the interdisciplinary nature. And because of the multi-pronged support that a patient gets through hospice. And that's why I have such incredible respect for social workers and nurses and chaplains. And this is why it's problematic sometimes when hospices are against assisted dying, because then the patient really does feel abandoned.
Right. They feel like they're on their own.
If their own hospice organization is against the one thing that they desperately have decided or want, then they're kind of at an impasse. But, and especially because a lot of hospices have policies against being in the room when the patient takes the medication, against mixing the medication. So they can be there at the event, but then they have to leave at the moment of ingestion, for instance, or they have to leave the premises and things like that. And of course, the patient that can also feel or land as a way of abandonment. But I attended hospice was called after the patient was deceased. In one case, the hospice nurse was waiting in the lobby of this assisted dying facility, and then they come in later, and then they can still catch the family, right? That's another important piece. The bereavement process is not always uncomplicated after an assisted death. Part of that has to do with the stigma, and we can maybe talk about that later. But one more thing I wanted to say, Helen, about something you mentioned earlier about the son and family dynamics, the dreaded family dynamics. It's really interesting, I think, and maybe you've seen this a lot in your work. At the end of life, family dynamics really come out that have long been hidden. And it's almost like a clarifying moment of where people stand. And the end of life really brings those types of family dynamics, both good and bad, to the forefront. And people have to negotiate these very complex characters, and years of hurt or years of other issues come out, and they all accumulate, not accumulate, they crystallize at the end.
So let's talk a little bit about that, about the grief and the bereavement, because it seems that it would be difficult for families after a death like this, because how do they explain? Oftentimes people will ask, if they didn't know about the death, oh, I'm really sorry to hear about, the loss of your mom or your dad, and how did it happen? And all of a sudden the family has to explain that that, their mom or their dad actually, took medication to assist in their dying. And I'm assuming there's a little bit of, not embarrassment, but just an unsettled feeling about this, about expressing this to someone, because this is still, I guess, culturally a little bit different for a lot of people, not always culturally accepted either. So what were some of the experiences that you saw when it came to family bereavement?
That's a really excellent question. A lot of families chose not to disclose the way that their family member had died, precisely for the reasons that you mentioned, that they were afraid of some of the enduring cultural stigma around hastening the end of your life and people's reactions. Because even in states where this has been legal for a long time, people still associate assisted dying with suicide. And I have a whole chapter in my book that talks about why assisted dying is actually a completely different concept and practical issue and legal and medical issue that differentiates it from suicide. So I'm not going to go into that now. But in the cultural mind, there's a lot of conflation there. And so it is as if a lot of these families feel that they can't grieve in the same way because their grief isn't societally allowed because of the way that the family member died. There's some stigma that clings to that, right? And in hospice circles, the term for that is disenfranchised grief. This idea that the way your loved one dies doesn't deserve the same type of attention or grief than other deaths, right? I'm thinking about a miscarriage. I'm thinking about a drug overdose or a suicide or something like that. And so a lot of family members who remain do not share how their loved one died, not because they don't stand behind it, but because they're afraid of other people's reactions. So they curate very specifically who is privy to that information. They do not advertise that, not because they are interested in being deceitful, but just because they want to manage people's reactions to that.
True.
Yeah, we'd think they would want to minimize their exposure to potential negative comments. You talk about Jean's daughters, the woman who had her daughters with her where the son was out of agreement. And when you met with them, I think about 6 weeks after Jean's death, that was one of the things that one of the daughters mentioned, that she did not disclose because she had a reaction from a coworker that was not condemning, but basically, I'm not sorry for your loss. I'm sorry that your loss was like that. When in fact, for the family and for the patient, for Jean, it was a very validating path. And it was very deliberate. She had thought it out. She knew exactly what she wanted. And she actually had great joy and enhanced quality of life from making that decision. And her daughters were able to engage in that with her, which is quite a gift. But to try to explain that to a coworker is so difficult.
Right. And so there is a way in which, people who have gone through an assisted death, right, the family members, they do feel a little alone because even in grief groups, they don't always feel like they can be completely honest about how this all happened because it's very hard to describe how you just described it, right? The empowering aspects of assisted dying, many people don't know about. Even the joyful, humorous moments at the end of somebody's life, if this is what they've chosen, if this is what they want, and they get to have this experience, because no matter what they are going to die, they are in hospice, they know death is coming, and they choose to do it this way, there can be a lot of agency in that. And I think that's also difficult to just explain to your coworker.
Yeah, especially in a casual conversation, that's not something that you would typically have water cooler conversation about at the copier, that kind of thing.
Right. And it's also, of course, there's grief. There's very similar grief as there is in other types of, no matter how somebody dies, there's always grief. But the studies that I have included in the book basically say there's less complicated grief after an assisted death. There aren't really as many thoughts of, oh, there's something I didn't say, or because people are able to prepare, people are able to get that space of acceptance a little bit easier, perhaps because they know there's a date. They know there's a time when mom is taking this medication, right? So if you want to say something, say it now. There isn't a surprise of, this is the day. And I think that's really, really important to come to that level of acceptance. And that makes for slightly less complicated grief. Of course, I've met patients who are still deeply in mourning of, the fact that they lost their partner, but not because of the way he died, but just because of the fact that he died.
Right. The loss itself.
The loss itself, not the manner.
One of the doctors that you reference in the book mentions that there's what he calls an uptick in the patient's morale and even in their physical ability once they actually get that prescription in hand. I thought that was interesting. It's almost like there is this, mental, physical connection that when they finally do get the prescription for the lethal drugs, that it changes their mental, their emotional concept. Do you think that's because they feel more empowered now, that they have the control back to their life? And there's even, he says, a physical change, that they become stronger, that there's almost like a rally that takes place. Tell us your experiences about that.
I think that's exactly what happens. And it's interesting. Many people have commented on that. Of course, there haven't been empirical studies on that, right? But I think it has to do with the way that patients feel that when you are suffering from a terminal illness, there are very few things that are under your control. And you're losing ability, you're losing parts of yourself every day, and you don't know what happens next. You don't know what capacity you will lose next and what is kind of in store for you. And I think for patients to have something in their back pocket, call it an ACE, call it whatever you want, is so empowering to know, if this becomes so unbearable to me, then I can just be the one who ends it. And I think that makes them embrace the life that they do have left much more daringly in some ways. And there's a relief that comes with it. And I talk about one patient in the book who got the prescription just to have that feeling, basically, of her mind at ease, peace of mind. She never ended up using the medication. And her husband later said, having the medication, knowing she has it in our cabinet, gave her back her life, essentially. And for those, I don't know how many weeks, a couple of months maybe, where before she ended up dying from something, actually from pneumonia, she was back to her old self, because she felt like she was in control in a situation that had made her feel completely powerless for so long, for years, basically.
So isn't this where hospice intersects with this? Because that's quality of life.
Absolutely.
That is quality of life, respect of choices, and hospice is all about enhancing patient and family quality of life. So to me, that's just another indicator of how the death with dignity, medical aid in dying, is not incompatible with hospice philosophy.
Absolutely, 100%. Yeah.
So Anita, would like to get just a little personal with you and ask you, how did this project change you, or did it change you? And if it did, how did it change your thoughts and your perspective?
Yeah, that's a really interesting question. I mean, I think on a broad level, I would say that it radically expanded my willingness to engage with death. I mean, like most of us, we grew up in a death phobic society. Most people don't ever really think very much about death. This really changed all of that for me. And I think it gave me a vocabulary and kind of a frame of meaning to think about death and what kind of experience that is. And also the work and care that go into death. Death isn't just something that happens, right? But something that is actively brought about. And I don't necessarily mean even with the medication or anything like that, but there's a process that has to happen. There's a process of detachment that has to happen when somebody dies, both for the person that's dying and for their family member, right? There's a slow process of letting go, of closing that chapter, of saying your goodbye, of trying to, and not in all cases is possible, but trying to make amends where you can. And just seeing how beautiful and heartfelt some of those moments are, and just how gracious people and brave people were at the end of their days. I mean, I found it really inspiring. I found it really, of course, sad. There were moments where I just left an interview and I was crying on the bike ride home. It's almost as if you attend these deaths, or you go through kind of what these people are going through at the end, and it's as if they're living in a parallel universe where the world around them keeps going, and yet you are in this bubble with this family that's experiencing something so intense and so meaningful, and it's very hard to then switch back to your ordinary life and go shopping or what have you, right? There's really something sacred, I would say, about these experiences, and that's what I try to convey in the book. So I think it's really this willingness to engage with death, I think, and the parallels between birth and death are really interesting to me, right? The way that we have home deaths, home births, the way that we have attendance to both. We have doulas, we have death doulas, we have, doulas who attend a birth. They attended my birth, and I was so grateful.
Yeah, that's interesting how, being present at those occasions, those events like that, I think it couldn't help but have an impact on you. So that's interesting. Thank you for sharing that with us.
I think anybody who's worked in end-of-life care, and you have worked in end-of-life care, not just for your research, you were a hospice volunteer. Mm-hmm. I think it changes you. It's meant to change you. And if it doesn't change you, what a loss. What a loss for you to be present to such a profound moment in someone's life and not be changed by it.
Definitely. Absolutely. 100%. And that's also, that goes back to the immersive approach. There's no way I couldn't then also write myself into the stories. A lot of journalists, or maybe who write books like that, they're not in the story themselves. But, and it's not that I'm on every page in this book, but basically I wanted readers to know what I was thinking as I was looking into these lives.
And it's very palpable in there. It's such a blend of observation and experience and science and the legal and ethical implications. And then the humanity, you sitting with Jean's daughters and talking to them, you talking with Joe, talking with the spouses and the families. It's very impactful, and I would really recommend it to any healthcare practitioner that works in end-of-life care or critical care. I think it's an important book. So you spent 5 years researching, writing. Is there anything that you would change about your experiences with the patients that were using medical aid and dying?
I think I would have tried to leave even more of my misconceptions or preconceptions maybe at the door. And as an anthropologist, you try to rid yourself of a lot of this kind of baggage already, and just actually observe what's happening. But I really strongly would say to my old self, don't assume anything. Don't assume that this is the saddest part of someone's life, because it isn't necessarily. And don't assume someone has to look a certain way to take advantage of this law, right? I remember catching myself thinking in a couple of instances when I met somebody, oh, they don't look sick enough to use this law. And of course, somebody who has 6 months less than 6 months to live doesn't have to look a certain way, and can suffer from all kinds of things that you don't see. But I remember thinking, and I'm obviously embarrassed by this, but I remember thinking, oh, I didn't expect him to still walk around, basically, or things like that, right? And of course, then really being open to the reasons why somebody is choosing an assisted death. And of course, besides, obviously they have qualified, they have this prognosis and all these things, but really listening when people talk about the fact that their physical self, is in pain or is deteriorating or what have you, declining. But then there's also this big existential piece of why someone wants an assisted death, right? Something like having completely lost sight of who they are, and this being an open wound of sorts. That's not physical, but in hospice philosophy recognizes that, right? The whole person, that you have this idea of existential suffering that sometimes we can't alleviate with medicine or with painkillers or something like that, right? If somebody lays in bed all day and has no purpose that they see for themselves and nothing to look forward to, and they would rather not be alive, then what do you do with that? And so I think it's the preconceptions that I wish I'd even been able more successfully to just not have going in, but I think it's impossible as human beings, right? We're so socially conditioned to see things a certain way. And so that's, I think, what I would do differently.
Interesting. I think that's a good lesson for every healthcare practitioner.
Definitely. Anita, I have to tell you, Helen has been reading your book and has been sharing a lot of the information in your book with me, but she has a lot of good things to say about it. And every time I ask her, what are you doing? I'm reading. What are you reading? I'm reading Anita Hannig's book.
And I share the stories, bits and pieces.
Yes. She obviously thinks it's a very important book, a very incredible book. The stories that you tell through the research that you've done, it's just amazing. So we would recommend to our listeners that they take advantage of reading your book. It's called The Day I Die, The Untold Story of Assisted Dying in America. And so we really do recommend that people take the time to order the book, read it. It's put out by sourcebooks.com. I'm sure they can also find it on Amazon.
Everywhere, indie bookstores, everywhere that sells books. And it's available as an audiobook, I should say, narrated by Linda Jones, who's incredible. When I listened to the audiobook, I couldn't believe I wrote it.
Well, we will have a link to sourcebooks.com and to your website and to Amazon where they can find the book. We'll have a link to it in our show notes. Anita Hannig, you are wonderful. You have gifted society with this book. As a healthcare practitioner, I'm so pleased to read it and to share it and to know you and your work.
Thank you so much. And thanks so much for reading so carefully. Thanks for having me. And thanks for bringing information about this really important subject to the public.
So hopefully you can see why we think this is such an important topic. It's a growing movement across the United States. We now have 10 states plus Washington, D.C., where a death with dignity law is on the books. Again, you don't need to endorse it, believe it's okay to use it, any of those things. You don't have to like it, but it's a good idea to be informed. Knowledge reduces fear. Thank you, Barbara Carnes. Right. So being aware of something. At the very least, if you know someone who's seriously ill and their family is helping them to take advantage or to utilize a death with dignity law that's on the books in their state, wouldn't it increase your compassion and your empathy for what they are doing or choosing to do? And how can that be a bad thing?
Yeah, it's not a bad thing at all. And what I like about Anita Hannig is that in writing her book, she immersed herself into those environments where it was happening. She got to know the people, the patients, the families, the doctors, the pharmacists, anyone who had any kind of a stakehold in this particular situation.
Yes.
She talked to them. She interviewed them.
People who didn't agree with it, people who wouldn't participate, physicians who were opposed to it for numerous reasons, in addition to people who had utilized the medical aid in dying.
Right. And she tells their stories.
Yes.
And so she's not writing this book to try to form an opinion one way or the other. She is telling the story as it happens. So we would encourage you to take a look at her book, inform yourself of what it feels like from both perspectives, and understand what is taking place. You can form your own judgment. That's what we want you to. But we want you to get the full story. And Anita Hannig has done the footwork for us. She's done the research. She's dug into this. She's immersed herself in it in a physical way even, being present when this was taking place. so that she could see firsthand what was happening. So you, as a practitioner, would be wise to read the book and hear what she has to say, understand the sides and the perspectives all the way around.
So if you're interested in purchasing The Day I Die, The Untold Story of Assisted Dying in America by Anita Hannig, you can find it in multiple places: Amazon, Barnes & Noble, IndieBound Books, Books A Million, Indigo, Powell's Bookshop, and it's also available as an audiobook. So for those of you who are on the road, or if you're a caregiver and your time is limited and you need to take it on the go, it's available as an audiobook too, and we would really recommend that you check it out. You can find Anita's background and the work that she's doing at anitahannig.com, and Hannig is spelled Hannig. So that's anitahannig.com, but of course we'll have links in the show notes for you to go straight to it.
Thanks for listening to The Heart of Hospice. I'm Jerry Fenter here with Helen Bauer. Because we know your hospice journey is 24/7, you can always find us at theheartofhospice.com. Please subscribe to the podcast wherever you're listening and leave a rating or a review on Apple Podcasts.
To connect with us, just send an email to host@theheartofhospice.com. You can also find us on social media. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.